Welcome to Module 6, Musculoskeletal Part 2. In this module, we're going to talk more in depth about fractures, the care of the patient with a fracture, traction, and task care. So fractures, musculoskeletal trauma accounts for about 66% of the injuries in the United States and is one of the leading causes of disability in the U.S. When we consider fractures, some of the things that we need to understand are our client learning objectives, such as communicating with the interprofessional team, ensuring that informed consents are signed before any type of procedure is completed on the patient, establishing priorities, handling hazardous or infectious materials such as blood or body fluids, maintaining asepsis technique when we're cleaning our wounds, maintaining confidentiality of the patient's health history, health maintenance, and health care, providing preventions for accidents or injuries, and then also providing physical therapy or occupational therapy referrals. Upholding the client's rights are ultimately most important for our nursing staff. When we're talking about skeletal anatomy and physiology, just refer back to week 5, module 5, with all of the stuff in the beginning. The types of bones, the density of the bone, the characteristic of the bone, and the bone growth. These are all going to correlate with how or if a patient receives a fracture. Now let's discuss the different types of fractures. So as you see in the photo here, there are closed fractures, open, transverse, spiral, comminuted, impacted, green stick, and oblique. A closed fracture is a fracture that happens the skin over the fracture area remains intact. A comminuted fracture, the bone is splintered or crushed, creating numerous fragments of the bone. A complete fracture is when the bone is separated completely into a break. Usually that's just two different parts, so it completely separates from itself. A compression fracture is a fracture bone due by compression of other bones. So for instance, these often happen in spinal injuries, say from lifting heavy weights. If someone's doing a heavy squat, this can happen. It causes a compression fracture. An impacted fracture is a part of the fracture bone that is driven into another part. So say, for instance, this patient might be in a motor vehicle accident. If they're one of those people that place their feet on the dashboard, and then on impact, the feet are pushed towards the body, this can happen, and an impact fracture can be caused to not only the tibia and fibula, but also the hip bone. An incomplete fracture is where the fracture line does not extend through the full transverse width of the bone. An oblique fracture is a fracture line that runs at an angle. An open or compound fracture, these are the ones where the bone's exposed. It comes through the skin and a soft tissue injury occurs, and it is a common place for infection. A spiral fracture is a break partially encircling the bone. Spiral fractures often happen on children. You will see a spiral fracture a lot of times in a child where a parent has grabbed the arm and like twisted it slightly. say for instance, they're trying to get their attention, or they might be abusive, or the child is pulling away and they grab them and kind of like tightly twist the arm. This can cause a spiral fracture. A transverse fracture is where the bone fractures straight across. So if you think about our literature, our lines in the body, transverse is our horizontal or vertical line straight across, okay? Okay, now, just remember that a fracture is a break or disruption in the continuity of the bone, what the different types of fractures might be, especially a complete fracture or incomplete fracture. The difference between the two, an incomplete fracture does not completely go through the bone. It's just partial bone damage. And I'm scrolling down here. Sometimes you will often see patients with compression fractures that have primary disease such as osteoporosis. So if somebody is complaining of pain with osteoporosis, this could be a compression fracture. All right, describe stages of bone healing in small groups. So these are going to be important to understand when we're talking about the care of the patient, because this will lead to whether we need to put them in traction or not. The first stage happens within the first 24 to 72 hours. The hematoma forms at the site of the bone. So think about the disruption of bone or tissue and what happens. We start to bleed. Well, the bleeding creates the hematoma. This is the body's way of starting to heal, right? So when we think about that, the first 24 to 72 hours, the bone is trying to clot off the damage and start the healing process. The second stage occurs 3 days in, up to 2 weeks, and it's called the granulation process. It's this part of the hematoma and granulation tissue process allows for the tissue to begin to invade the hematoma. So basically the bone actually starts to heal, and it's not just the blood clot holding the bone fracture together. It causes a release of fibrocartilage, and the foundation of the bone starts to actually come together. The third stage occurs as a result of vascular and cellular proliferation within 3 to 6 weeks. So this part is when we start really feeling the release of pain, and people have less tenderness to the side because the bone is actually in that a good space where it's really healing. This is called the callus formation stage. So the third stage, you may see in someone that is able to start bearing weight, okay? Say, for instance, if they have a long bone injury or a ankle injury or something to that effect, or a joint injury. When you're in the third stage, you want to consider this one, because that's when you're going to see the patient actually be able to perform more activity. The stages of bone healing, stage 4 is in week 3 to 8. The callus is gradually reabsorbed into the bone the healing process is almost complete at this stage. And then the 5th stage is the consolidation or remodeling. This is where the bone actually starts to resolve, the fractures resolving. It's usually about 4 to 6 weeks in. This actually, it can take up to a year to heal this part of the bone healing process, depending on the patient's health condition. And it also depends on the severity of the injury. Some important things to remember about fractures. We're going to look for signs and symptoms of beginning complications that must be treated to prevent serious consequences. Common acute complications of fractures include venous thrombosis and bone tissue or soft tissue infections. So venous thrombosis includes deep vein thrombosis and its major complications of pulmonary embolism. It is the most common complication of lower extremity surgery or trauma, and it's most fatal when it comes to pulmonary embolism, okay? So if we think about DVTs and PE, some of the things that we need to consider are, if we have a patient that starts to complain of acute pain at the site after surgery, we'll need to really check for distal pulses from the site. You want to check for capillary refill and make sure that it's less than 3 seconds. And you want to consider the color and temperature of the extremity. So you're looking for, is it cool and pallor? Does it have a pulse? And are they complaining of pain and tingling? If this is the case, you may have a problem with the fracture site. If the skin is warm, non-tender, and pink, those are normal signs. If the skin appears warm to touch and painful, swollen, and red, this is abnormal also. So those are things that we would want to identify on inspection and palpation and tell our physicians about. Clostridium infections are very important to identify also. These are gangrene or tetanus type infections that can prevent healing of the bone. These often happen with open bone fractures or surgical repair of a fracture. So there's, then again, this here is something totally different. Signs and symptoms would be more like patient starts to run a fever. Their vital signs might be a little bit tachycardic. They may have symptoms of some pain at the site, redness, again, swelling, the signs of infection, and or a pussy or purulent drainage coming from the site with a smell. If this happens, the thing you need to do is identify it and by inspection, and you're going to call your physician for orders. So what are the main causes of fractures in the U.S.? Our aging nation, for one, we're getting older. Healthcare has kept us alive longer. So many people are getting older. As we age, there are the risks for osteoporosis. As we age, other neurological conditions cause falls, and failure to use recommended safety equipment on recreational activities. Some of those things would include a patient not wearing pads when playing sports, such as a helmet or shoulder pads. They may not wear a seatbelt when driving. These lead to more extensive types of fractures. It's really important for us as the healthcare provider to educate not only our younger people, but our older people on musculoskeletal injuries such as fractures. We would educate on how to avoid falls in the home, such as removing rugs, making sure that there is a lighted area for a pathway from the bedroom to the bathroom, that the floors stay dry, and there's no tripping hazards. So modification in the home is really important sometimes for our population. Let's talk about the health assessment or things you might see. Determine the type of injury. So when we're looking at injuries, there's different types of injuries. There's incisional injuries. These are often related to knife or surgical wound, or they could be crush injuries and can lead to hemorrhage. When we get further in, you will learn more about how to control hemorrhage, but we're not going to get into that today. Acceleration, deceleration injuries. These, if you think about acceleration, deceleration injuries, they are direct trauma to organs such as the brain, the spleen, and the kidneys. When these acceleration, deceleration injuries occur, if you remember the contra coup injury, like the brain hitting the front of the skull and then bouncing back and it damaged both the front and the distal portion of the brain, you will remember this one. Shearing and friction. So shearing and friction, you're going to see again, because it is something that happens commonly in healthcare settings because of the way we reposition and position people. It can lead to high levels of wound contamination. So understanding the difference between shearing and friction are really important. Take medical history. That includes, we're going to look at recent drug use and history. So drugs do affect how wounds heal. Just remember that NSAIDs can delay wound healing, especially bone wound healing. So it's important to understand what kind of medications that the patient may be on. Other things that can affect wound healing is also anticoagulants or blood thinners. Corticosteroids also can affect wound healing, but we want to be just conscious or understand the different types of drugs and basically what is going to slow the bone healing at this time. And really, it's the NSAIDs that most physicians are kind of concerned about. Some occupational and recreational things that we need to ask the patient about is what kind of sport activities they may be participating in. This is going to be important to understand for their therapies and wound healing, because if they're a non-weight bearing patient or if there's an extremity that needs to be immobilized, they won't be able to perform or participate in their activities. So understanding that is going to help with your plan of care and how you're going to help the patient identify what they can and can't do. History of bone cancer or osteoporosis is also important. It definitely is two things that weaken the bone structure. And if a patient has repeated fractures, they may need assistance with devices to help prevent falls or help keep them safe. And just remember that like some activities like jogging or running can actually cause fractures such as tib-fib fractures or shin splints is what we call them sometimes. It puts more stress on the hip, knee, and ankle joints. So you may see patients come in with those types of injuries. When we're considering our physical assessment, the first thing we're going to do is our pain, right? We're going to ask them the PQRST or old carts or cold spot, any of those that identify what the pain is. So if our patient comes in with complaints of pain, we're definitely going to ask them where it's at. Where's the location at? Have them point to it if they cannot talk to you and let them be the identifier. When did it start? We want to know what the onset was. You know, you need to ask them, hey, when did this start? Is it something acute or have you had some chronic pain? The duration of the pain, we're thinking about asking the patient questions such as, is it intermittent or is it constant? Are you having like sharp stabbing pains, or is it chronic ache? Characteristics such as the ache or the stabbing pain are going to be indicative of what type of injury it is to the tissue. If you consider the different types of locations or radiation of pain or referred pain, it's going to also tell you a lot. You're going to ask the patient about what helps alleviate the pain. Are they using ice, heat, ibuprofen? Have they done anything for the pain? You're going to ask them about time-sensitive things, such as, like I said again, is it intermittent or consistent? Always having the right questions is going to be a good idea. Okay, so as we're assessing the major body components for trauma, some other things that we're going to do is the vital signs. We're going to look for healthy vital signs. If they don't have healthy vital signs and they have a high heart rate, maybe they are in pain. If they have a high blood pressure, maybe they are in pain. If the patient cannot void, we need to look for, is there any damage to the pelvis or the pubic area? When assessing the site for a possible fracture, observe for bone alignment. So we're going to do this on inspection. When we walk in, if a patient's complaining pain of an extremity to a body part, we're going to look for symmetry. We're going to make sure that both sides are equal, right? Is there anything protruding or anything that doesn't look normal from one side to the next? Is there any internal or external rotation? So with a hip fracture, what you're going to often see is a externally rotated foot on the side of the fracture. One of the or more bones may be dislocated. So if you're looking for symmetry and a shoulder is lower than another one, could possibly be a dislocated shoulder. Is there any shortening to the extremity? If this occurs, that usually is a complete fracture and the bone has shifted upward into the skin tissue. Change in bone shape. Like again, are there any nodules to the site? You could probably palpate it and feel, but I would be very gentle if you touch it because the patient's going to be in a lot of pain. Is there any ecchymosis? Ecchymosis is bruising. So if there any bruising over the area of the fracture, it's a good indication that there's bleeding at the site and we need to be cautious with that fracture. We're also going to perform a neurovascular assessment. We're going to look at the skin color, like I said, distal to the injury. So wherever the injury is happening, we're going to check for cap refill. We're going to look at the color of the skin. We're looking for temperature of the skin. Can the patient move the extremity, or can they move the parts distal to the extremity? Do they have sensation? Are they able to feel you touching them, or do they have paresthesia? Paresthesia is slight numbness or tingling to that area. Do they have good pulses? Identifying what level at their pulse is very important. Easy. Also, you want to note whether it's bounding, whether it's soft or normal, or whether it's really weak. If it's weak and thready, you have a problem, and that's something that needs to be addressed right away. And then we're going to assess the pain. Okay, we're going to go through all those questions that I had just mentioned. All right. Psychosocial assessments, when we're talking about injuries, especially severe injuries, we're really going to do some psychosocial stuff with these patients. Say, for instance, they've had a spinal cord injury or a spinal injury that's affecting the spinal cord. The length of rehab may be considerable. So some of the things that we want to consider is how we are going to address rehab with the patient, if they are mentally stable enough for rehab, what support systems they have and what support systems they don't have, because we may have to find them the support systems they need in order to get them through this time where they're having to either be immobile or they may have lost some type of function to an extremity. The nursing process, we've done this a few times now over the last few weeks, and we've talked about the nursing process and how to set up nursing diagnosis, how to set up SMART goals, and how to identify our interventions. This is really the way that we take care of our patient. That's why it's so ultimately important for you to understand how to do this. And when we're talking about nursing diagnosis and analysis, consider with a fracture, a lot of times the patient is going to have acute pain. They may have impaired mobility. They may have a risk for neurovascular compromise. Now, remember, neurovascular compromise is when there is a complaint of numbness and tingling to the extremity. They may not have good pulse to the extremity, and it's they have found that they're not able to move it. Okay. When the patient we're diagnosing and looking at the symptoms and everything that might be correlated, we also want to make sure that we identify their risk for infection. Is it an open fracture that they've got bone protruding and that it's open skin? Because remember, the skin is our largest organ in the body. It is what protects us from infection. But when it's open, they're more at risk. If it's a closed fracture and it's something that has to be surgically repaired, they are going to open the skin. So then again, it sets them up for risk of infection. So what are some things that we want to educate our patient on? The main thing that I would want to educate my patient on is hand washing. Proper hand washing and aseptic technique when cleaning dressings are going to help the patient refrain from getting an infection in that site. Planning outcomes. So when our patient comes in and we're dealing with their acute pain, the patient will verbalize pain often of a significant amount, maybe a 6 out of 10. We're going to go with that right now. What our goal is, what we want to do is make sure the patient can verbalize a pain level that is what would be considered more normal or tolerable. So anything below 3 would probably be something that the patient can tolerate, and they're not going to be in a significant amount of pain. So when we're thinking about writing nursing diagnosis or a plan of care, and then we're making this an intervention, we definitely want the patient to verbalize a pain level that is tolerable for them after medication is administered within a certain amount of time. So you would want to go back and reassess the patient for their pain. And usually you want to give them about 30 minutes to an hour and do the reassessment and see what their pain level is. Some other things that we want to do is increase mobility. So how are we going to do that? Well, one way is by teaching them how to use their mobility devices. Encourage them to use the call light, making sure that they have proper shoes on. Those are things that are going to be really important with increasing patients' mobility. When we consider preventing or monitoring for neurovascular compromise, the best way that we can do that is by capillary refill and sensory perception assessment. So we're checking, can they feel you touching them? Do they feel pain or tenderness? And what does the extremity look like? Are they having cold, pallor, or is it warm? Those things are going to play into your assessment and planning of neurovascular issues. And when we're talking about neurovascular compromise, you're going to find that with fractures, there is a thing that can happen that if too much swelling occurs to the site with a wrap or cast on, it is compartment syndrome. And compartment syndrome we'll learn a little bit more about after week 8. when we're considering this, we have to monitor for the swelling, okay? That is a neurovascular issue. When we're preventing infection, we're going to talk to and educate the patient on, like I said, hand washing, keeping the area dry and clean. We're using aseptic technique to change dressings, and we want them to adhere to their antibiotics. Okay, if they are on an antibiotic when they leave the facility, they need to continue the antibiotic until it is done in order to prevent infection. If they don't take it and to its full extent, the body can actually build up somewhat of a little bit of a immunity, and then it may be harder to fight off an infection once it has started. Okay. Interventions for emergency care. So when a patient comes in through the emergency department, some of the things that we are going to do initially are we're looking at the dependent injury, and we're going to see how severe it is, right? We're going to expose the area of the injury to assure accurate assessment. So what we're talking about right now is like our primary survey when we go in the room. We're looking at the patient. How are they responding? Are they crying and upset or in pain? We're going to look for the extremity. Which one is bothering? What's hurt? We're going to undress it. We're going to get it to where we can see the tissue, see if there's any damage, okay? If there's any bleeding at the site, we're going to control bleeding with pressure. You're going to put something on it to create pressure, and usually it's going to be your own body. So you're going to grab a hold of it and put direct pressure on that fracture. We do not want anybody to bleed to death due to a fracture. Common problems with femoral fractures are the risk of bleeding because there is an artery that runs along the inner portion of the thigh that sometimes becomes disrupted and will bleed. If this artery bleeds, the patient's at risk for bleeding out. So always direct pressure. It's going to cause them pain. Warn them when you do it. Advise them that it's for their best interest, and try to encourage them to participate and not fight you on it, because they may fight you if it's hurting them, right? When we're considering prevention of shock, place the patient in supine position, okay? You're going to make sure that they're getting fluids, and we're going to give them some medication for pain. We're going to splint the injury, and then we're going to manage the pain after it has been taken care of with some type of medication. Now remember, if you have a patient that has an opioid addiction, they may refuse opioids for pain management. At this point in time, if it occurs and you have a patient refusing opioid management, try to encourage them to do other things to help relieve the pain, such as maybe some of the CAM therapies. You may have to work with them because it's going to be hard on them if this is the case. All right, some of the best practices for patient safety and quality. We're going to assess the patient's airway always. This is going to be priority in your nursing questions. When you see a patient and it asks you anything about which patient you're going to see first, which assessment you're going to complete first, or what treatment you're going to do first, airway, breathing, and circulation will always be number one, okay, you guys? So that said, once you've assessed their airway, breathing, and circulation, and it seems to be okay, you're going to perform a quick head to toe. We're looking at everything. Is everything symmetrical? Do they have good color? Is there anything that doesn't look quite right that I need to focus on, right? Then I'm going to start removing patient clothing if I have an interrupted area. You want to check all the pulses below the injury, making sure that there is no problem with blood flow to the distal portion of the from the injury. If the patient has shoes on during a trauma, such as an ankle break, do not remove the shoes because this can increase the trauma to the ankle or injury. Allow the physician to do that, okay? Apply direct pressure on any area that is bleeding. Always, always, always remove jewelry to an affected extremity. So for instance, if someone comes in with an arm fracture and they have rings on, or a hand fracture and they have rings on, remove the jewelry so that you do not have to cut that off due to the swelling to the site. Keep the patient warm and in a supine position to prevent shock. Check all neurovascular statuses of the distal area, including temperature, color, sensation, movement, and cap refill. Compare the affected side for asymmetry to the unaffected side. And immobilize any extremity that might have a fracture with splinting. This includes joints above or below the fracture site, and recheck for circulation after splinting. So what we're going to do is we're rechecking for circulation. We're going to splint the site, and then I would not wait too long, maybe 15 minutes or so, and I would go back and make sure that I'm checking for circulation. Unless the patient starts to complain sooner than that, if they complain of numbness and tingling after you've wrapped the site, you need to check the site immediately and contact the physician. Cover any open areas with a dressing, preferably a sterile dressing. Now, here are some interventions associated with non-surgical management of fractures. And this is a lot of the stuff that we may do as nurses. So we're going to look for prevention of neurovascular compromise. We're going to complete our check of the patient every hour for the first 24 hours. Now, with that said, this would be somebody that would be admitted to the hospital. If you have a patient that's going home, this nursing intervention would not be appropriate because you're not going to be able to assess them every hour for 24 hours, correct? So what you could have the patient do is you could teach them how to assess their own neurovascular compromise. Are they having acute pain more than what the medication is treating? Do they have any numbness and tingling to the extremity below the injury site? What does the skin temperature look like? Is it cold, blue, pale? Those are things that they need to know are important to come back to the emergency room for. Every 1 to 4 hours after the injury has happened, follow the agency policy. So they're saying every 4 hours, you're going to do a neurovascular check. If a patient complains of increased pain that's not relieved by analgesia, this is a sign. So you want to make sure that you're telling the patient come back or let you know that the pain is not being relieved. The extremity is usually elevated above the level of the heart, so always remember the elevation of an extremity will help decrease edema to the site. And applying ice to an area to reduce edema may help. Just always remember that applying ice causes vasoconstriction. If the patient does not have good circulation to the extremity already, this might not be advisable. Okay. Cast care. Now, this is important stuff here because you are probably going to be educating your patient on the cast care. When we're discussing cast, there's some specific things that you need to understand. Plaster, fiberglass, and air casts are used to immobilize bones and joints and correct alignment after fracture or injury interventions. Some of the interventions are keeping the cast and extremity elevated. Remember, we're going to try to prevent swelling by doing that. If you have a patient with a wet plaster cast, it may take it up to 72 hours to dry. But what we're going to do is we're going to handle a wet plaster cast with the palms of our hands. Okay, so you want to pick it up from underneath until it is dry. You don't want to pick it up with the fingertips. The fingertips could compress the cast in on the extremity and cause pressure points. So you don't want to touch it like that. You want to grab it with the palm of the hand. A hair dryer can be used on the cool setting to dry a plaster cast. Heat cannot be used on a plaster cast because the cast heats up and burns the skin. So this one, I would be cautious with advising the patient to do that because most hair dryers don't have like an actual cold setting. It's like a cool air, but not cold, and it's still warm. So for sensitive tissue underneath the cast, this actually could cause damage if it's not done properly. So just be careful if you're going to educate on using a hair dryer for cooling under the or cooling the areas in the cast. So and also be aware if a patient is complaining of a hot spot on the cast, it wouldn't be advisable for them to use a hair dryer to cool it because most likely that's a site of infection and it needs to be looked at. So if they're complaining of a hot spot, they need to go get seen, okay? Not try to treat it on their own. Monitor them closely for circulatory impairment. We're going to keep going back to that because it's super important. Also making sure that they maintain the smooth edges of the cast. So if the cast for some reason does get wet and it starts to crumble, they need to go back to the physician. Always educate your patient on monitoring for signs of infection, the hot spots, any foul odor, or changes in pain sensation. So if they've increased pain above what analgesics are treating them for, if they have hot spots, if they have an increased temperature, or if they start smelling a foul odor, these are ominous signs of infection, so they need to be seen. If an open draining area exists, the primary healthcare provider will make a cutout portion of the cast known as a window, and this will allow assessment of the wound site. Always instruct the client not to stick objects down inside the cast. No scratching with clothes hangers. Teach the client to keep the cast clean and dry. One of the things that you would want to do is advise them to not take showers while wearing a cast. If it's on a lower extremity, they may want to take a bath and always keep the leg out of the bathtub. And always instruct them to do isometric type exercises to prevent muscle atrophy. So a lot of times the joint below the fracture site is going to be immobilized. If this is the case, you're going to have to teach them ways to utilize the joint above the site to kind of help prevent some muscle atrophy to that extremity. Remember to monitor casts for circulatory impairment, such as pain, swelling, discoloration, tingling, numbness, coolness, and diminished pulse. Notify the healthcare provider if this happens. This could be circulatory compromise. Once the cast has been removed, we're also going to do some education with the patient. When we remove the cast, the patient can utilize like lotion to take off the dry skin that might be there because sometimes people will have flaking and scaling of the skin after the cast comes off. So they can use some lotions to help soothe that. Tell them to expect a decrease in the size and range of motion of the extremity. So once a patient's placed in a cast, the immobility of the muscle causes atrophy. Have them support the extremity with pillows until their strength returns. Have them slowly start into their exercise or rehab program. And advise them to always wear support hose for any kind of lower extremity injury. Okay, traction. This is not used very often today, but It is used more at a level 1 or level 2 trauma center than you would probably see in most other places. The problem with traction is there is a high risk for infection. So learning how to take care of a patient in traction is really important, and there's so many things for traction that we need to know. On page 873, it goes into the different types of traction and fixation. So we want to be aware of the different types. One of them that you are going to see is Buck's traction. So Buck's traction is for the lower extremities. It's a type of skin traction used to alleviate muscle spasms and immobilize the lower limb while maintaining a straight pull on the limb with the use of weights. A boot appliance is applied to the attached traction. So it's literally like this boot device that is set up to a pulley system with a weight that sits on the floor. Now, the weights are attached to the pulley and they're allowed to hang freely over the edge of the bed sometimes. Not more than 8 to 10 pounds is usually used. The elevated foot of the bed helps provide the traction. So we're always going to keep the foot of the bed elevated somewhat. Some of the considerations for the traction that we want to remember are looking for the avascular necrosis or compromise, so you're going to make sure that there's no swelling to the site, that they have good blood flow, that type of stuff. We're just protecting them. Now, Buck's traction, remember, is the boot. There's other types of traction, so we'll read through those real quick. The Russells is going to be the type of traction where there's a sling for like the upper extremity. The Hoffman, it's for the hand, so you may see a device that's placed in the hand, and this is a type of external fixation. Okay, so knowing what internal and external fixation is also is going to help you with the care of your patient, because some of the tractions you're going to see the patient has these nuts and bolts hanging out of their skin. These are the different types. So let's talk about skeletal traction. We said it screws directly into the bone, which allows for heavier weights. Sometimes this is up to 15 to 30 pounds. Client is immobile, so they'll need to be monitored for complications of immobility. When we're talking about complications of immobility, we're talking about respiratory status, cardiac function, bowel sounds. We're going to be doing all of these assessments every shift and pretty frequently, because we want to make sure that the patient doesn't start to have atelectasis from lying in the bed and not being able to move. You want to make sure that they don't have any cardiac compromise due to the weakening or immobility, because they're going to be immobile, so they're not using that heart muscle to function. And then you also want to be aware that constipation can occur, or the patient may develop ileus from being immobile. So doing cardiac, respiratory, and bowel sounds every assessment or every shift is a really, really good idea for these patients. We're also going to assess the equipment. We're going to look at the ropes, pulleys, and weights every shift to make sure they are placed where they're supposed to be. So there's certain alignment that the physician will have them in, and if it's moved from that, it could damage the alignment. So we're going to make sure it's in place. If a patient reports severe pain and realignment or repositioning does not assist the patient, then that's a primary care provider issue. They need to come to assess the patient. And then we're going to monitor the pin sites for any infection. Now, understand that when we do pin site care, It's important that you do a couple of things. You're going to make sure that when you're caring for the pen site that you use like a sterile water and sterile gauze to clean around the site, and you're going to clean from the center of the site outward. So you want to clean the area most affected by the pen out away from the site. Never ever use a cotton ball or anything that can break and shear into the pen site, because if these fragments of tissue, or I'm sorry, gauze are left behind, or cotton ball are left behind, then that sets the patient as a risk for infection. So, as you know, fractures are pretty painful. Opioids such as oxycodone are often used. There are some non-opioid treatments like Tylenol and NSAIDs. Just remember that NSAIDs will slow bone healing. If you have a patient, again, like I said, that doesn't want an opioid, might want to encourage other CAM therapies to make sure that they are getting good treatment and they are staying as comfortable as possible with the different types of fractures. Some things that you can do is advise them for heat and cold applications. When we're considering patient-centered care and the management of pain, clients who have impaired sensory perception might not feel numbness, pain, or burning. So one of the things that with them, you definitely want to have them monitor the tissue site. Anti-inflammatory products, you're going to be looking at the NSAIDs and muscle relaxants are commonly given for patients that have had severe fractures and maybe in traction. So some of the muscle relaxers you may see them on are like Flexeril. This can help. Sometimes they'll be put on Neurontin also to help with nerve pain. As a nurse, we're going to try to promote mobility for our patients. So when we're talking about promoting mobility, there's a couple things that need to be considered. So when we look at the system as a whole, we're thinking, okay, the effects of immobility on this patient, how are we going to prevent them? We're going to collaborate care with other physicians, we're going to therapy, occupational therapy. We're going to get everybody on board for this patient's care. We're going to teach the use of the assistive devices like the walker or the cane. We're going to prevent the complications of immobility by educating the patient, really. We want to get them up and moving as quick as possible. So teaching them proper body mechanics is going to be important when we're thinking of skin. We want to talk about some of the things that come along with the damage. We want to do our assessments for breakdown. We're looking for pallor, bony prominences. We're checking skin tumor. We're having them change positions at least every 2 hours. We're observing for any urinary or bowel incontinence. We may have the patient identify these risk factors back to us. They may have to use pillows, boots, roll, the trochanter roll, or even wedge pillows to help reposition them. You want to make sure that you're turning your patient at least every hour to 2 hours to support any kind of tissue integrity. You want to teach your client who can move independently to do things such as heel pumps to decrease cardiovascular risk, the DVT risk, okay? You want to provide skin and perineal area care as frequently as possible, especially if they're unable to get out of bed. Some of the respiratory things we can do for a patient is We're going to definitely assess the chest wall movement on entry to room. We're looking for lung sounds. Are they diminished, crackles, or wheezing? Are you observing for a cough? Have they coughed up some sputum that might have a noted color? All of these things need to be documented. When we're considering our nursing actions, we're going to reposition the patient every 1 to 2 hours. We're removing for any abdominal binder that might be in place every 2 hours and making sure the placement is correct. So this would be for someone that may have an abdominal binder due to a back fracture, okay, or an abdominal surgery. You may have to use chest physiotherapy if they're immobile for long periods of time to prevent atelectasis. You're going to monitor for any ability to expirate secretion. So if your patient starts to get weak from immobility and they're unable to cough up any kind of congestion that's in their chest, this is setting them up for risk of pneumonia. So you want to get it moving. One of the best ways to do that and help open up the lungs is to provide them an incentive spirometer and teach them how to use it. Okay, so take a look at how to use an incentive spirometer because this is good advice for all patients that are immobile for any period of time. We're going to have our patient, we're going to educate them on turning, coughing, and breathing at least every hour at minimum. You're going to have them try to yawn, opening the airway that way, using the incentive spirometer. And if the patient has no contraindications for their fluid intake, you're going to increase their fluid intake a little bit to at least 2,000 milliliters a day. Some of the preventing infection stuff that we need to be aware of is dressing changes with aseptic technique. We're going to monitor vital signs for temperature and heart rate. Remember I said that if the patient starts to have some pain or even sign of infection, the heart rate's going to elevate. So they may have a high heart rate. Administer broad spectrum antibiotics as ordered. Gentamicin and clindamycin are two broad spectrums that have been ordered in the past, and we've started ordering Ansef, which is another. And it's usually given at the time of surgery. If you have to irrigate a wound with an antibiotic solution, generally, there are specific orders for this, and a lot of times an advanced nurse practitioner or a physician will do the antibiotic solution flush. Sometimes wound care nurses also do. You won't see this much on a med-surg floor, but most likely in critical care type areas. Some medical assessments, we're looking at laboratories, so we're going to check the H&H, which is the hemoglobin and hematocrit. This tells you how much red blood cells are circulating in the body, how much blood the patient has. The erythrocyte sediment rate indicates the amount of soft tissue damage when a fracture occurs. Elevated white blood cell count during the fracture healing process actually is normal for the most part. So a small elevation in white blood cell count is going to happen. It's the normal body process. If the patient has a extremely elevated white blood count, say for instance, our normal range should be below 10. If they present with one that is 15, this is an indication that the patient may have an infection. Serum calcium and phosphorus may be elevated during the healing process. So if you remember the structure of the bone, we have phosphorus and calcium within the bone. If the bone fractures, it's going to seep out into the bloodstream. So when it talks about serum, they're talking about how much calcium and phosphorus is actually in the blood, okay? Imaging assessments. When talking about what we're going to do to identify diagnosis. Standard x-rays are performed. Sometimes CT scans will be performed, especially if the pain complaint is in the hip and pelvis, because we're going to look for soft tissue damage, such as any bladder damage, bowel damage, or any other organs in that area. MRI shows extent of soft tissue damage. So if the patient goes to CT and they see a fracture and they see something else that might be going on, the patient's also going to probably have to go to MRI. Or if the physician suspects that there might be more damage in the pelvis area, say for instance, that they're urinating blood. Once you put a catheter in and there's blood presenting, then they may send the patient directly to MRI to see what type of organ damage has been received during the injury. Surgical management, open reduction and internal fixation. Now, here's where we were talking about the types of traction and what you might see. So when the pins are placed, right? So internal fixation, let's talk about that for a second. Okay, let's understand what the different terms are first. So reduction, what is reduction? Reduction is the restoration of bone to proper alignment. So when you think about reduction, it's almost like they're pulling the bone back into its proper alignment if it's moved out of alignment. There is a closed reduction. This is a non-surgical intervention performed by manual manipulation. Okay, so when we're thinking of closed reduction, we're thinking of popping a joint back into an area, or placing a bone back in its proper alignment without having to open the skin to do it. A cast may be applied to the area for this procedure once it's completed. If open reduction involves surgical interventions, a fracture may be treated with what we call internal fixation devices. So that's where the surgeon views the fracture site, places pins or screws, blades, and sometimes prosthesis to allow the bone to heal. If you look at your NCLEX book on 873, gives you a picture of a hand that's in one of these devices. Open reduction with external fixation. When we're talking about open reduction, remember reduction is just the placing the alignment of the bone in the proper positioning, but open is when they're surgically repairing it, right? They're opening it up. So with an open external fixation, this usually happens when there's an external frame placed to stabilize the fracture by attaching skeletal pins through the bone, and it's attached to a rigid support system. So when we're talking about like the box traction or some of the other tractions, that is the type of procedure that's going to occur prior to placing them on the device that keeps the bone in the spot that they want it in. So some of the things that we need to know are external fixation provides more freedom of movement. Okay. Monitor the pin site stability is important, and keeping it clean. So we're going to make sure that we're reducing the risk of infection by aseptic cleaning. External fixation is commonly used with massive tissue trauma is present. Remember, this type of repair is used when a fracture involves tissue damage, okay? And it makes it easier to monitor the healing of the tissue. The patient is at greater risk for infections at the pin site also. When we're considering the type of patient that might have external fixation, always remember this is someone that's been probably in a massive trauma or massive accident that has open skin areas and bone protruding. When we're considering the most common type of reduction, for immobilizing a fracture, it's usually going to be the open reduction with internal fixation. So instead of having the pins and everything exposed to where you can see them, they're actually going to put the metal device within the bone structure and then close the skin back up. So they're going to suture it back up. Okay, this can happen. A lot of times we can do this for upper leg fractures. They can do a open reduction with internal fixation, but it is the most common one that is done in comparison. Some complications associated with fractures are going to be the acute compartment syndrome. I talked about this a little bit briefly earlier, and this is part of our neurovascular compromise. It's most common in the tibia of the leg and the tibia and forearm, but has other causes. So that one I would just say it's common in the extremity areas where, say, if you have some type of injury to the lower extremity, the distal portions of our extremities, lower arm, lower leg. Related to the muscle, blood vessels and nerves are caught within the fascia. So what happens with acute compartment syndrome is the injury occurs, swelling starts, the body just overreacts and really like swells immensely. When the swelling occurs, it compresses the blood vessels and the nerves distal to the site of injury. Unfortunately, we have to have blood flow and nerve impulse to our distal portions of the injury. If that is blocking that stuff from getting to the fingertips, the hand, the toes, the foot, or anything below the injury, this is when compartment syndrome becomes a problem. It does immediately lead to increasing pain that is not relieved by medication. It can cause tissue necrosis. If there is no blood flow, the patient may lose their digits. If unrelieved, it can lead to amputation. So that is the worst case scenario. We have to identify it. How do we identify it? We're checking for pulses. The patient does not have a good pulse to the extremity and they're complaining of extreme pain. They may be starting to have compartment syndrome. Be aware that it may appear within the first 6 to 8 hours after the injury and can take up to 2 days. So it may not happen immediately. One of the assessments that we are going to do for compartment syndrome is our 6 Ps. We're going to look for pain, pressure, paralysis, paresthesia, pallor, and pulselessness. So when we're considering the 6 Ps, the most common complaint is the pain and pressure. Paralysis is a late sign of compartment syndrome. So if the patient cannot move the extremity, this is very ominous. This is bad. Paresthesia is that numbness and tingling that the patient may feel due to the lack of blood flow. Pallor to the site is going to be that cool, white, or pale looking skin. And then, of course, pulselessness is due to the blood vessels being compressed and no blood flow getting to distal injury. When we consider compartment syndrome, one of the things that the physician is going to do is possibly a fasciotomy. When the top part of the fascia or the skin that surrounds the muscle becomes compressed like that, we have to release it. So once again, we're looking for that unrelieved pain, any tissue that looks pale, dusky, or edematous to distal to the site. the loss of sensation. If this occurs, we're notifying the primary health care provider. We're going to continue to elevate the extremity because we're going to make sure that no more swelling occurs while they're waiting. You're going to loosen any tight dressings. So if they have a cast on, you may need to cut it off. And then the last resort would be the fasciotomy, and it's a surgical incision to the tissue to open it up, and it allows the swelling to occur where the swelling actually will protrude out of the area, releasing some of the tension that's placed on the nerves and blood vessels. If a patient has acute compartment syndrome, again, I'm going to repeat this, loosen the bandage or wrap. If a cast is present, you may need to remove it. You're going to notify the primary care provider immediately. That's going to be like as soon as possible, okay? You want to decrease the damage first and then notify the primary care provider. Though if it's asking you a priority type question, you want to actually get blood flow to that extremity at all costs. Do not elevate, it says, or ice the extremity. Now, okay, so the PowerPoint says do not elevate or ice the extremity. But in your NCLEX review book, some of the interventions say to continue to elevate the affected extremity. So elevation of extremity, remember, is going to help decrease the blood flow to the extremity, but it's also going to help decrease the swelling. So you do want to keep circulation as much as possible. Probably going to teach that. This may be treated with a fasciotomy. We've talked about that. Once the procedure of a fasciotomy has happened, remember, it's an open wound. We may have to pack that wound with sterile gauze 4 to 5 times a day. We're going to be looking for bleeding. We're going to be looking for infection of any sort. So knowing the signs and symptoms of both is going to be ultimately important to keep your patient safe. Hemorrhage or hemovolemic shock. Bone is avascular, so since there are blood vessels in bone, if a patient, say for instance, has a long bone break, like a femur fracture, they're at risk for hemorrhage. Trauma to this bone area and the result of bone loss is going to be indicated through vital signs. So you're going to check vital signs. What does their blood pressure look like? Are they presenting with nausea and vomiting? Are they dizzy? Are they having any other symptoms that may present coming along with blood loss? So when we're considering assessments for hemovolemic shock, we're going to look at the site. How much bleeding has occurred? Is it swollen? Is it bruised? Do they have a hematoma? What is their blood pressure? Are they hypotensive? Are they tachycardic? These are signs of hypovolemic shock. When we're discussing hemorrhage and hypovolemic shock assessments, remember vital signs, blood pressure, heart rate, increased respirations, decreased urine output. Anything below 30 cc's an hour is not enough. That patient is at risk. Prolonged capillary refill, anything more than 3 seconds, that patient is at risk. The next thing is fat embolism. Now, fat embolism can be caused by a long bone fracture also. It's a release of fat globules from the yellow bone marrow. Usually this happens immediately, really, when the fracture happens, but sometimes it can take up to 48 hours for the fat globule to be released into the bloodstream. Now, these can present in different manners. You may see a patient present with shortness of breath. They may be confused, or they may be complaining of pain at the site of injury. These are all indicative of a fat embolus. They're common in hip fractures and long bone fractures. They often happen between the ages of 20 and 40 in men, and then older adults such as 70s and 80s. Early signs and symptoms are going to be hypoxemia. They're going to be short of breath. They might have an increased respiratory rate. So those two signs are ominous, and we really need to pay attention to them after a patient's had this type of injury. Some late signs are non-palpable pulses, red-brown petechiae, or macular like looking rash all over the body. And what we're going to do for them, we're going to send them to chest x-ray if this occurs. If you're seeing these symptoms, you want to make sure you get a chest x-ray to make sure that they don't have any infiltrates. An infiltrate basically can be any outside source. So it can be fluid from the body accumulated through like a bacterial infection, like pneumonia or flu. It can also be something like the fat embolism or a blood clot. So when we're thinking of DVTs, they can also go to the lung, okay? So fat embolism syndrome is common to people with these types of injuries. Some of the symptoms, absolutely the shortness of breath and hypoxemia. So hypoxemia can be identified through respiratory rate pattern and O2 saturations. They may complain of headache if they're short of breath, if they're not getting enough oxygen. They may complain of the headache. Okay. Also, if the embolism has went to the head, it may be a type of stroke. So you have to be aware of that. They may present sleepy and weak or lethargic. They may be confused, agitated. They may have a decreased loss of consciousness. Seizures and visual changes are really late neurological signs, so that's not really good. And the last symptom is that red-brown macula, like rash on the neck or upper arms and chest. This also can present with the fat embolism. Venous thrombosis or venous thromboembolism, or DVT, are the leading cause of pulmonary embolism. Okay, so get a DVT in the lower extremity, it breaks loose and travels to the brain or the head. As nurses, we're going to do prophylactic treatments with the patient. One of the things is Lovenox or heparin. So you're going to see a patient that may have a lower extremity fracture due to a trauma, receiving Lovenox or heparin. Making sure that you identify the proper dosing with these anticoagulants is super important because too much of these drugs can cause bleeding. So you want to make sure that you're aware of the proper dosing. TED hose. So TED hose can get placed on people with a lot of edema. This helps prevent DVT. Sequential compression devices, or SCDs, are commonly used in hospitals for anybody that's admitted. A lot of times it's really important to encourage our patients to continue to wear these because they're kind of hot and they will complain about them, but it will prevent the risk of DVT if they're not real mobile. And then encouraging them to do foot pumps. This is going to help with any cardiovascular compromise that may come along with that immobilization. Infection. So we're looking at infection of a wound site. There's the osteomyelitis is a bone infection. So try not to get osteoporosis and osteomyelitis confused. Remember, we had talked about osteoporosis being that porous bone. Well, osteomyelitis is an infection in the bone. It is when the bone has developed some type of bacteria. Usually this happens with open wounds. they can be hospital-acquired infections. So, how do we prevent hospital-acquired infections? The one way you're going to prevent them is wash your hands, making sure you're using good hand hygiene on entrance and exit of the room, that you're always using gloves before you touch a patient. All right, let's talk about avascular necrosis some. Avascular necrosis is related to disrupted blood flow to the bone. It's caused by hardware sometimes. It can also be caused by disease. So if you consider someone that is, say they have osteoarthritis, and osteoarthritis decreases the blood flow to the distal portion of the bone, or where the joint occurs. If this blood flow has slowed, then the bone itself will deteriorate and die. So this is a vascular necrosis, okay? And when we have hardware, it is often that this type of necrosis happens in the hips if hardware is involved. Common in patients treated with long-term prednisone therapies also. So when we're talking about medications and avascular necrosis, corticosteroids actually kind of slows the blood flow in bone. So it unfortunately will set the patient up for ischemic necrosis to the bone. All right, delayed union. This one here is when the bone doesn't heal. Okay, so it's not healing within the 6 months so that a common bone would heal. The common tibial fracture is a place that this generally happens. That bone is thinner and people start to bear weight on the site too soon sometimes, and this will cause delayed union. It can lead to chronic pain if it doesn't heal properly. So when we're discussing delayed union, remember it's a fracture that has not healed within 6 months. Some fractures never achieve union. These are called non-union type of fractures. If they heal incorrectly, they're called malunion, okay? These problems are most common in patients with tibial fractures, again, fractures that involve many treatment techniques. So they may need casts, they may need traction. They can often be pathological fractures. So when we're considering a pathological fracture, think about osteoporosis. A patient that has that porous bone, it's weak, they actually can cough really hard and break a rib. That is a pathological type fracture. Another thing you would want to consider is like cancer patients. Cancer of the bone weakens the bone. These people also can have spontaneous or pathological fractures. Delayed union interventions or treatment. So if a patient is having a hard time with the bone healing, some of the treatment processes might be electrical bone stimulation, bone grafting, and low intensity pulse ultrasound. Complex regional pain syndrome. Complex regional pain syndrome is formally called reflex sympathetic dystrophy. It's a poorly understood dysfunction of the central and peripheral nervous system that leads to severe persistent pain and other symptoms. Genetic factors may play a role. Complex regional pain syndrome most often results from a fracture or traumatic musculoskeletal injury, commonly occurring in the hands or feet. This dysfunction is a central and peripheral nervous system dysfunction. It may be genetic, and it primarily happens in the hands or the feet. Assessment, signs, and symptoms. We're looking for that change in color, the temperature, the sensation to the skin. Does the patient have any excessive sweating? Now, with the complex regional pain syndrome, there's a triad of symptoms that present. Okay, these abnormalities are autonomic nervous system changes. So that's why you're going to see the color, temperature, and sensitivity changes to the skin. The excessive sweating and edema can occur also to that extremity, which is kind of strange because a patient might have like sweaty palms or sweaty soles of their feet. They may have some motor symptoms that come along with it, like paresis, muscle spasms, or loss of function. If they have an altered sensory perception to the site, this increases their risk for receiving burns or other injuries to the site. A lot of times these patients suffer from osteoporotic bone changes over time. Here are some interventions. So we're talking about pain management. You can use topical or oral analgesics. Sometimes we will use like lidocaine topical patches to help with pain management. Anti-epileptic medications, antidepressants, corticosteroids, and biphosphonates may help with pain management of a patient with this condition. Minimal stimulation when providing skincare might be important for someone that has a sensory deprivation or sensory problem. If you don't want to rub too hard and damage the tissue, because they may not feel you actually touching them well. Peripheral and spinal cord neurostimulation is used to deliver external or internal electrical pulses to block pain. When a patient has chronic pain issues, say for instance, they've had a spinal cord injury or they've had a fracture in the spine, they may end up with an implantable device that helps remove some of that pain stimulus from the nerve. Drugs such as phentolamine is injected into the spinal cord sometimes. This is done by a physician. Surgical procedures called sympathectomy or cutting of the sympathetic nerve endings might happen. And these surgical procedures can have a profound psychological effect on the patient and may require therapy or a support group. Health promotion and maintenance. Some of the things that we're going to consider when we're treating our older adults, some of the education they need, are going to be our physiological changes. So some of the physiological changes, really for them, it's going to play into a lot of their psychosocial stuff too. So we're going to look at their sensory perception, their gait, their balance, their muscle strength, and their joint stiffness. Disease changes, if they have osteoporosis, you're looking on how to educate them on prevention. So some of the things that you might want to do is advise them not to smoke cigarettes, drink too much caffeine, or drink alcohol. All of these things can lead to osteoporosis. If it's a foot disorder or things that you might want to consider with those types of people is advising them to wear the right kind of shoes. Maybe do like stretching techniques in the foot. If it's a bony metastasis, then that is something that we're really going to be trying to just alleviate pain symptoms and change in cardiac function. As far as our education for our older adults, we need to make sure that they stay active, that they're changing positions, that they move from one position to the next gradually without standing up too quick because they can have orthostatic hypotension. You're going to teach them range of motion exercises and try to make sure that they're just staying mobile. They may need to incorporate some of the other therapeutics like the sequential devices, the low heparin or Lovenox. And then you want to also educate them on in contacting their care provider if they have any problems with cardiac function. So drugs, some of the things that we're going to discuss with older adults are diuretics. So furosemide and the other diuretic will, I can't remember the name at the moment. Anyways, it will actually set the patient up for risk for falls. So if you think about what diuretics do, diuretics help you pee. If they have some cardiovascular changes and they've been put on a diuretic to make sure they don't have fluid overload, the patient often has frequent urination. And if they are at home alone and they have a weak gait or unsteady gait, it's important for us to advise them about how the diuretic works, when they should take it so that it doesn't affect their sleep, or how to prevent fall in the home by making sure their walkway is clear. Antihypertensives, antidepressants, sedatives, and opioids, all of these drugs will set the patient up for risk for falls. Environmental factors such as throw rugs, loose carpet, floor clutter, inadequate lighting, and uneven work surfaces or steps, and even pets can cause a fall. One important thing to remember, always educate your adults and your driving age children about airbags and seatbelts. This will decrease seriousness and of injury and death if a motor vehicle accident happens. Also encourage them not to put their feet on the dashboard. This can also cause lower extremity injuries. All right, guys, this is the end of Module 6, and here are your references. Have a good one.